Today's webinar is titled How the Pandemic Changed Our Laboratory and Health Systems Perspective on Point-of-Care Testing. It will be moderated by Dr. Leslie Donato. Dr. Donato is an associate professor of laboratory medicine and pathology at Mayo Clinic in Rochester, Minnesota, and is a laboratory section co-director of the Hospital Clinical Laboratory and Clinical Specialty Laboratory. Dr. Donato's research spans a wide range of clinical areas, including critical and point-of-care testing, cardiovascular and lipid biomarkers, and biomarkers of gastrointestinal function. Pertinent to the topic of today's webinar, Dr. Donato led the implementation of point-of-care testing of molecular infectious disease throughout the Mayo Clinic enterprise in 2018, and has been actively involved in the evaluation, implementation, and maintenance of all SARS-CoV-2 point-of-care tests at Mayo Clinic. Dr. Donato, thank you for moderating today's webinar. I'll turn it over to you now to introduce the speakers.
Thank you very much for that introduction, and it is my great pleasure to introduce to you our three speakers today in today's session. The first speaker will be Dr. Karen. Dr. Karen is a professor of laboratory medicine and pathology at Mayo Clinic in Rochester, Minnesota. He is chair of the Division of Clinical Core Laboratory Services and co-director of the point-of-care testing program at Mayo Clinic, Rochester. Most of Dr. Karen's academic career has focused on critical and point-of-care testing. Second, we have Dr. Gardner, who is an associate clinical professor and director of clinical microbiology at UCLA Health System. He received his PhD from UC San Diego in biomedical sciences and was a postdoctoral clinical microbiology CPEP fellow in the Department of Pathology at UCLA, and a former McNair Scholar. Dr. Gardner is a board certified by the American Board of Medical Microbiology and focuses his research on novel point-of-care devices for infectious disease diagnosis in the developing world. Lastly, we have Dr. Kumar, who is a clinical chemist with more than 15 years of experience in the field. He trained in both clinical chemistry and molecular diagnostics and worked in the diagnostic industry for 4 years before moving back to academia. Currently, he oversees diagnostic labs as medical and CLIA director within the UT Southwestern Hospital System and is an associate professor in the Department of Pathology at the UT Southwestern Medical Center in Dallas, Texas. The main focus of his clinical research is on assay development and clinical validation. I will now turn it over to our first speaker, Dr. Karen.
Well, thank you, Dr. Donato, and I'm going to cover today how COVID and the pandemic changed our perspective on the evaluation and development of point-of-care tests for our practice. So I think you all appreciate that COVID-19 brought on what was in my career an unprecedented need for additional testing capacity. Very early in the pandemic with the White House task force that was focused on large reference labs and the ability to get high throughput methods up and running because there simply wasn't any testing available. But it quickly became apparent that local testing was going to be the really key to addressing the pandemic. And that included just the need for local tests for faster turnaround time during surges, but also rapid methods that supported pre-procedural testing, keeping our hospitals open, hospital admission testing to preserve PPE and protect healthcare staff, emergency department testing, and certainly testing within conjugate group home environments to prevent these horrible outbreaks that caused so much death early in the pandemic. Also unique to COVID-19 is that, and I've spent most of my career in point-of-care testing, those of you who also spend time in this field know, at any given time, there are dozens, if not hundreds, of potential new point-of-care platforms out there. They were developed in academic chemistry departments, bioengineering departments, people's garages, and they have some feasibility data showing that a new novel platform might work with one particular analyte And that's where they stall and end because there's no money to really take it from this proof of concept to a test that has a FDA validated test and produced at scale. Well, the government through BARDA and Department of Defense and other mechanisms started pouring in hundreds of millions of dollars and really reached out to all of these, the world of startups to say, if you've got a platform and a dream, show us it has potential and we're going to give you truckloads of money. And so that resulted in this rapid acceleration of these companies submitting EUAs and pursuing their first ever diagnostic test. So back in the summer of 2020, I was asked in the Mayo Clinic enterprise to lead a point of care innovation team. And this innovation team, the job was to reach out to these companies that were developing assays because we needed more rapid testing capacity in our enterprise, and to interact with them and figure out, well, which ones had enough potential to bring in-house and evaluate ourselves. So while the EUA was being considered by the FDA, we could decide, is this a reasonable platform for us? So we started really taking all offers, and everybody had a friend of a friend who had this platform that was originally going to do something else, but now it was a COVID test. And so we were overwhelmed just with the number of companies and groups to talk to. So we quickly developed these evaluation criteria to say, well, who even is worth, what platforms are worth bringing in-house to evaluate? So EUA pending or approved, obviously EUA approval would be great, but at least EUA pending. But we really began to realize there were things differentiating these potential startup companies' platforms. Many had very limited detection and data from a conventional type experiment. Many had almost little or no field data like clinical sensitivity, specificity, and we preferred multiple users and multiple sites, and that was a rare exception. Many had almost no data, field data. Data management, and again, a lot of these companies said, well, we've got this platform and it connects to an iPhone, and that's great, but iPhones don't really get us any closer to putting things in the LIS and EMR than a notepad or a clipboard. Hands-on testing time. You'd think point of care companies from the beginning would realize you need to minimize the time to test, but some had multiple steps, mix this, shake this, invert this, transfer this to that. And so hands-on time was one. Having the RNA extraction and amplification contained in a single disposable device was key. Many did not, surprisingly. They had multiple steps and you did amplification here and you moved it over to this platform to read. And obviously in a point of care environment, the environmental contamination could be insurmountable. We wanted to make sure our staff were protected. Early days, again, we didn't know doing testing could give people COVID. It actually hasn't turned out that way. And then we looked at antigen tests with different criteria. Going on, we again wanted there be no specific training, so truly designed for point of care, not for laboratory technologists. Have disposable reagents, consumables. And then as we begin to identify a handful of promising platforms and decide which one to bring in-house for evaluation, we began to ask, well, okay, now we have 2, 3, 4 that we're evaluating that have potential. How do we know which other ones to look at next? So then we began to, after all, compared to the ones we've already committed to evaluate, does the new one, and because there were dozens of new ones, have a faster result in improved limit of detection, fewer steps, or have it addressing some of the environmental contamination and safety issues like a direct sample to answer platform that doesn't use a media or VTM, or an inactivating buffer to protect our staff. And then I mentioned data connectivity being key. As we began to experience a little bit of platform fatigue, we thought, well, we don't want to bring in all these new platforms for one test. So when we have other tests this platform would be good for that would work. And then again, what was the plan for the company to ramp up production beyond the handcrafted several hundred they might have used for their EUA study and for an evaluation? So one of the companies we work with, and the company sponsoring this webinar, Fluxergy, we began to work with them in May of 2020. And Fluxergy had developed a 1-hour card-based RT-PCR method. And at the time, that was pretty fast. And having RT-PCR as opposed to isothermal amplification promised good sensitivity. This test works as a digital imaging inside of a card, 6 wells in the card, 6 both target and control amplifications being monitored in the 6 wells. And then we evaluated this starting in May of 2020, and we found that with different lots of card and reaction mixture they would ship us, that both the false positive rates and the invalid rates of tests would go up and down, and some lots would look pretty good and some were very concerning. So it was around this time, and again, being in point of care field, I know that a lot of existing long-term use FDA approved tests that really have great single lot data from a manufacturer or a single study in an academic center struggle with long-term performance and accuracy of the test due to lot-to-lot variability. And there's data on hemoglobin A1C, INR, and glucose, all being affected by lot-to-lot variability that may really reduce the performance of the test over long-term, even when a shorter-term study looks good. So it was around this time the CAP Foundation was soliciting grants for the John H. Rippey grant for expedited research to improve the quality of COVID testing. And so I submitted an application and we got funded under this grant. And this was a lab industry partnership, 3 labs, 2 academic, 1 community hospital, with 1 company, Fluxergy, to understand whether rapid feedback from end users could improve the performance of a RT-PCR rapid test for SARS-CoV-2. So the setup was the company would send a lot consisting of 10 cards and 10 reaction mixtures, all from a single lot, to the 3 end users, the 3 labs, every couple of weeks. On our labs, we would test 5 previously positive and 5 previously negative, so 10 tests per lot. And we return those results to the company. But beyond just the results, concordant or discordant with the reference method, which was the Roche COBOS method, we would return the raw data so the company can actually see, well, what's happening inside that card that's causing a discordant result or an invalid result, and use that information, especially the raw data, to improve test performance. So we started the study. The study design was that we would return results to the company from all sites every 1 to 2 weeks. They'd use that, they'd look at that, change lot release criteria, lot QC processes, shipping processes, and improve performance. Well, a study like lot of studies didn't work the way exactly we intended. The 3 sites had trouble keeping up with the lot shipments. And so rather than returning, 30 tests every time, the first 3 lots were done. That's 30 tests times 3 sites. First 90 results were all returned to the company at the same time. That was 45 positive, previously tested positive, 45 previously negative samples. So again, we had difficulty keeping up from the sites. We gave all the data back to the company on these first 3 lots, 90 results. What we found was a very high rate of first run error codes. And in most instances, the rerun gave the intended answer, but obviously if you're doing a point of care test and 40% of the time it returns a error code and you have to redo it, it's an hour test. That's going to be frustrating. And a 6% rate of discrepant results with about 9% presumed false negative, 2% presumed false positive. What happened at that point is the company took all this raw data, and rather than quickly, the study was paused about 6 months, and they made, and I won't read them, all these modifications, which include both the intended process, things like lot release criteria, lot QC, shipping, but also major changes to both the hardware and software that were made in response to this end user data. So then we went back and resumed the study. We had a study design called for 7 more lots. We sent all of those 7 lots out at the same time. One of the 3 sites had dropped out, so we had 7 lots, 10 tests each times 2 sites, 140 test results, again, 70 previous positive, 70 previously tested negative samples. Rate of error codes reduced dramatically from 44% to 4%, and only one of 140 results tests was a discrepant result versus that reference method, the Roche COBOS. So this really looked much more promising, really consistent with our minimum criteria for rapid tests that we developed over these, what I described before of the rounds of working with vendors of error rate less than 5%, false positive rate less than 1%. So what did we learn? Well, we learned that yes, end user feedback, which was the point of the study, can improve test performance. The lab industry partnerships can accelerate development of more robust diagnostic tests. And this is a model I hope will be used during other times of crisis. However, a lot of the technology redesign processes took a lot longer than we intended. And certainly when you get into changing hardware and software and changing your impact in the regulatory approval process, it takes much longer. So again, doing this earlier in the test development lifecycle might be more effective. So with that, I will turn over the presentation to Dr. Garner.
Wonderful. Thank you, Dr. Karen. I appreciate that. And so my presentation is called Changing Expectations, the Impact of COVID-19 on lab testing. So just a brief introduction to our health system, which I think is becoming more common as health systems. We have two tertiary quaternary level hospitals. And over the last decade, we have expanded as a health system to include about 300 outpatient care clinics. Some of them specialty, some of them urgent care, just a very mix covering a large part of the Southern California basin. The challenge here is we have to think differently then from a lab medicine perspective as we approach health systems like this. And then we were faced with an extremely complex disease. And so I'll call COVID-19 a complex diagnostic challenge with various needs. And this graph, and we've really just started to analyze this data, represents test volume in my laboratory for COVID-19 testing. And I call my laboratory sort of anywhere where COVID-19 testing is being done, not only my Clin Micro Lab, but also the point of care tests that I had built throughout our system. And we contrast or compare this test volume, which is seen on the left axis, with positivity rates. And so that's the orange rate that goes through. And so what you can see through the course of the pandemic is we had a quick ramp up to about 600 to 700 tests per day within our system, including asymptomatic and symptomatic testing that lasted throughout the course of the pandemic. And then as the pandemic peaked, and so I put here, if we'll remember, wild type SARS-CoV-2, and then alpha, the alpha peak, the delta peak, the Omicron peak, and then the consistent Omicron peaks, our lab testing needs fluctuated throughout this environment. And so what I needed for Omicron was really different than what I needed for Delta. Now, we didn't know that at the time. And so what I really want to walk through with this particular presentation is how those changing needs affected our ability to provide laboratory medicine resources and tests around this particularly challenging disease, and again, impactful, right? We all work for health systems where our health systems were shut down, our ICUs were full, we couldn't take any more patients, 25% of our staff were out with COVID-19. I mean, just challenge after challenge over the last 3 years. So I'm going to start this with the first need, and this was March 2020. We were looking at it already, and the answer was we need a PCR test, right? We need an in-house test to be able to do COVID-19 PCR testing for our patients. We had been sending to the CDC, we had been sending to LA County Public Health, and that wasn't working. So as soon as we were allowed by the regulatory agencies, we actually brought on, as a laboratory developed test in my laboratory, a modified version of the CDC test, sort of fixing some things for us, but its throughput was low. We could run 120 patient samples per day. We had extended some of the acceptable specimens. This was about our sort of very sick, hospitalized patients. The problem with this initial test is it was very labor intensive. So it required extraction, and we had multiple extraction devices we were using. You'll remember there was a run on extraction reagents overall that was happening. The PCR setup was 96 well plate, but it was 3 wells per patient as you set it up for each one of the different targets. And then we'd run RT-PCR and ABI 7500. So very low throughput, slow turnaround time. We could do 2 runs a day. I mean, you could just imagine thinking now in 2022 what that test could provide for the future of COVID-19. But we brought it on, and we brought it on early, and it had impact. But very quickly, we moved to the second need. And that second emergency need was we need an inpatient ED, so inpatient and emergency department COVID-19 PCR test that had a shorter turnaround time and could provide higher volume, right? We're making our way into the pandemic. 120 tests a day batched at 8 hours was not going to cut it anymore for the number of patients we were seeing going through. So we partnered with diagnostic companies, and I'm going to mention some diagnostic companies throughout this presentation, but you could put in the diagnostic company you were working with at this time, right? All of them had different types of tests, different turnaround time, and it was really about filling the need. So we worked with DiaSorin to provide us a COVID-19 PCR test. We had already had 11 of their instruments in-house doing other types of testing, and we were able to do about 300 COVID-19 PCR tests a day on this particular system. Quicker turnaround time, right, because you didn't need extraction. So it was a 90-minute PCR runtime. It was one of the first platforms to get EUA. We were able to validate some of the lower respiratory sources, and it solved the need. It solved that immediate inpatient testing need. And if you look over the course of the 3 years of the pandemic, we've performed about 135,000 of these particular tests. But very quickly, a new need arose. We need a high throughput outpatient COVID-19 PCR test. As we learn more and more about this disease, we learned, of course, that not only did symptomatic outpatients need to be tested, and symptomatic disease, remember, we are growing now into alpha and the alpha peak and then moving into delta. Symptomatic disease testing was going to come in at a very, very high level, and for the disease distribution for this particular disease, asymptomatic testing was going to start becoming important. So we realized at this point that 300 tests a day wasn't going to be anywhere near to suffice from an outpatient perspective. So we partnered with Thermo to be able to bring on their TACPath kit, and the throughput in our lab was about 1,000 tests per day. Even though it was relatively high throughput, we had to batch run it, and the turnaround time was going to be extended, so 18 to 24 hours, which was fine in the outpatient setting. You'll remember that people were waiting 7 days for COVID PCR tests at this point. So our 24-hour turnaround time was still really good for our UCLA outpatients, but this was also a very manual process. I didn't mention last time, I'm showing you some pictures from the inside of my laboratory. I'm sure all the laboratorians on this call will smile to think about how their labs were remade during this time to be able to accommodate COVID testing. But for the Thermo test kit, you start with the Kingfisher. We didn't have Kingfishers, so we had to work to bring those in. Then it's a manual PCR setup, and it was one well per patient. So on a single plate, you could do 90 instead of 30, but it's still the RT-PCR endpoint on the ABI 7500. We had to get more ABI 7500s. We had to actually bring staff from other parts of the laboratory, bacteriology staff, mycology staff, to learn how to do this molecular testing to meet the need in this setting to get up to that 1,000 tests per day marker, but we were able to achieve that. Now, I'm going to take a little bit of a side road here before we get into sort of some of the other things that we needed, including point of care, because I think a question comes up, especially from a lab director perspective, but also from a laboratorian perspective and a patient perspective. I now have multiple PCR tests that are supposed to do the same thing, right? I'm running a CDC RT-PCR test still for my lower respiratory specimens. I'm running this inpatient ED sort of 1.5 hour test for that population, and I'm running an outpatient TACPath, all at relatively high volume, especially the inpatient and the outpatient. Do the tests perform the same? We validated them all, but its performance on validation material versus its performance overall on patient testing, and we actually published this work in late 2020, is important for the tests for the lab community to think about, right? Because you don't want to offer a bad test, right? I don't want to say, well, the outpatients get a test that's about 80% sensitivity, and the inpatients get a test that's about 95% sensitivity. And you'll remember at this time, the sensitivity of the PCR test was very much in question, right? Lots of people thinking they were getting false negatives. We're realizing now, of course, that was about specimen quality, not necessarily the PCR themselves. But we looked overall. We did some comparison analysis for the total number of tests that were done between the testing platforms, looked at the general positivity rates, looked at the general inconclusive and invalid rates, and then what's not shown here, we did some equivalent testing. Take the same sample and test it on all the platforms. And what we saw is that they all had about equivalent sensitivity. So this is great, right? And this is something that as labs think about expanding not only what they're running in-house, but also point of care, these types of comparisons are critical, especially in talking to your physicians. They need to know where your tests are weak and where your tests aren't weak, and the types of tests that are being received as we look at modalities of more than one test for a single analyte. So we moved on, and we moved on because we didn't have enough tests. So if you'll remember Omicron, this was a huge influx of the number of positive patients in the outpatient setting. Our positivity rate got up around 35 to 40%, and we needed to be able to bump up to test thousands of samples a day, more than 1,000. So at this point, we were able to get our hands on a 6800. The people on this call will remember these instruments weren't available. We were in a queue, finally landed, and we were able to expand to add an additional 1,000 tests a day. So outpatient testing, 1,000 on the Thermo, outpatient testing, 1,000 on the Roche, and we're now up to 2,000 tests a day. More automated, which is nice, but still we're doing all the Thermo work, so it's not like automation has sort of taken over the entire process, but puts us at a high number. And what's a little bit cut off here is we are close to now combining in our outpatient setting, having run about 600,000 COVID-19 PCR tests on these platforms to support what goes on. But none of it's fast, right? I got about a 2 to 3 hour test on the inpatient side. I have about an 18 to 24 hour test, high volume on the outpatient side. But we need something faster. And so in about October 2020, we realized very much that even at a 1.5 to 2 hour turnaround time, we had a set of patients that was not going to be fast enough. We needed a rapid COVID-19 test for our emergency department and inpatient patient care with an average turnaround time of less than 30 minutes from sample collection to test results. So why do we need this as a system? So COVID-19 procedures, and this was PPE procedures, very much affect patient care. Meaning if a patient came in and you knew they didn't have COVID-19, the amount of PPE that was on for that patient care was less than if you knew they did have COVID-19. If you didn't know at all, then of course the infection prevention opinion was you have to treat them like they have COVID-19. And remember, with our understanding of asymptomatic transmission of this particular disease, especially in the pre-vaccine era, this was a concern, right? Healthcare workers were catching diseases were being passed in the hospital overall because we just didn't know who had COVID and who didn't have COVID. And so for this test, we were looking for a test that could provide rule out of COVID for emergency procedures so we can deal with our patients with trauma and stroke and know they didn't have COVID-19. Transplant screening was really important as well. Transplants were counterindicated for people to have COVID-19, and we are one of the largest transplant centers in the country. And so our transplant program was being ground to a halt because we didn't have a fast enough COVID-19 answer, same-day surgeries and emergency surgeries, and a lot of that asymptomatic testing. And then we needed critical patients being admitted with respiratory symptoms to know whether or not they should go directly into our quote-unquote COVID-19 wards. So all of that required a fast test. Now, you'll remember the landscape at this time, and as Dr. Karen pointed out, there were a lot of available quote-unquote fast tests. So you had the array of antigen tests to choose from. You had the rapid molecular tests that were based on LAMP technology, so they were not PCR. And then at this point, there were a couple of rapid molecular PCR platforms available. So we had all of these to choose from. And as I was evaluating, outside of the package inserts that were making claims that all of these were equivalent across the board in sensitivity, working in point of care infectious disease for a long time, I knew they weren't all equivalent. As much as the data had come out around antigen testing that it was going to be the same as PCR, we knew that wasn't true. And so I had to really think about, well, what were we looking for here? And because of the rule out procedures, we were looking for a test that was reliable results on asymptomatic patients, which means I needed exquisite sensitivity for the test that we're looking for and a great negative predictive value as a negative rule out. So because of that, I eliminated antigen testing as a possibility, and I actually didn't even look at the rapid molecular non-PCR test because I hadn't seen data that was strong enough to suggest to me that that was going to match the PCR results. And so we went forward with one of the rapid molecular PCR platforms. Again, hard to get a hold of, lots of negotiating with the company, and then we were still set at a pretty low level of the number of these tests we could perform a day. But we went forward with the rapid molecular PCR from Roche, the Roche Cobas Liat. It had a 30-minute turnaround time and max, so 80-ish tests per day. And if we look overall, we've done about 70,000 of those tests so far as a system. And we were running those point of care or at least near point of care, either in our EDs or in our ED stat labs. And then I ran it a little bit in my clinical chemistry laboratory for things like surgery. So kind of our first foray into point of care, but again, we went extremely sensitive in that direction. But then a new need came up. And so post-Omicron, right, I guess during Omicron, what we saw was that, 25, 30, 40% of our staff had illness. And there was a 10-day waiting period before people could come back in from a overall quarantine perspective. Well, if 30% of your staff is out for 10 days, you have to shut things down in the hospital system. So you'll remember at this time, the CDC came out with a recommendation. The recommendation was after 5 days of illness, if a patient was feeling better and was non-feverish, they could come back to work and wear a mask. Now, this made a lot of us very uncomfortable because we knew even after 5 days, people could be highly symptomatic, and we didn't have a good test for understanding the level of virus in these people. So it was thought at this time that a point-of-care test could maybe fill this need. And that point-of-care testing would be antigen testing. The idea with antigen testing was that, yes, we acknowledge that antigen testing has less sensitivity to PCR, right? PCR can be positive 15, 20 days after illness, long after a person is actually infectious. But antigen testing seemed to correlate better with something like viral culture. And so the detuned nature, the less sensitive nature of the antigen test actually fit in well with what we needed as a system. And so I brought in the Quidel Sophia 2 antigen test. Rapid results, we actually sort of lined our healthcare workers up, had them come in the day they were going to return to work, sort of day 5, post-infection, no more fever, and we would run the antigen test. And if the antigen test was negative, they could return to work. So we took advantage of the lack of sensitivity. And this is really honestly the first time I'd ever even considered this from an infectious disease perspective, this idea that lack of sensitivity was going to be an improvement for what we needed from a healthcare system. So we ran thousands and thousands of these tests because so many workers were out but wanted to and could return to work. If you look over here at this graph, and we published this data as well, was everybody antigen negative? No. If you look at day 5, day 6, day 6 is where we hit about that 50% threshold of people that were antigen negative and could return to work, but we returned a lot of people to work at that day 5 post-symptomatic infection because bringing this type of point-of-care test on. And I think this is a nice contrast, right? We needed a point-of-care test for rule-out for emergencies that weren't related to COVID, and we needed a point-of-care test for rule-out of potential contagiousness so people could come back to work. Those two questions aren't the same. Those two needs aren't the same. And so it really brought into play a lot of different point-of-care modalities that we could use for success in our system. So what did we learn? I learned a lot through COVID. I direct clinical microbiology, but I direct point-of-care testing as well. And historically, we take a one-to-one test-to-target approach. If I've got one gonorrhea test, that's the test I'm using as much as possible. Yes, there's always been an acknowledgement that like flu antigen testing and RSV antigen testing has been out there, but I think from a lab medicine perspective, a lot of that has been ignored. A lot of that has been sort of seen as the realm of point of care. But COVID-19, I think, really changed that for health systems overall, even in the hospital side. The COVID-19 pandemic revealed a need for many different test types. You have to consider turnaround time. My PCR inpatient didn't match what I needed for my PCR outpatient. We have to consider sensitivity and capacity. but all for a single disease and a single target. So I would like to, hopefully you take away, there was not one test platform that could have served all these needs. There's a push-pull between high throughput testing and rapid results, but we need to be, as clinical lab leaders, open to and embracing of these various testing modalities for complicated diseases. And I list some other things that I think we need to think better about. Influenza, RSV, gonorrhea, chlamydia. I think more and more diseases will fit into this. So I will close and pass over to Dr. Kumar.
Thank you, Dr. Governor. I'm going to focus on test utilization in post-COVID era today. As you all know, COVID pandemic has brought considerable attention to lab medicine. Lab testing remained as one of the pillars in containing the spread of the virus. Access to testing, lab testing can improve patient care. Nearly 70% of all medical decisions are based on laboratory testing. However, barriers to lab testing still remain, especially in our rural areas, outreach areas, and especially in our marginalized communities. Even before the COVID pandemic, working in the HIV field, I have seen firsthand how bringing a rapid HIV test in high-risk population can contain the bulk of the spread. During the COVID, initially there were some hiccups with testing, but once they were stabilized, more rapid tests become available in our neighborhoods, in our communities, later in our home. Simplicity of testing, convenience of testing, and rapid results was appreciated by everyone. Thus, the importance of point-of-care testing became obvious during the recent pandemic. For this reason, it is expected that both testing volume and test menu of the point-of-care tests are going to increase rapidly in the post-COVID era. One of the major concerns with increased accessibility to testing is overutilization. Some of the studies have shown that nearly 1 in 5 lab tests ordered are unnecessary. Over-testing can lead to false positive results, leading to wrong diagnosis and unwarranted additional investigations. If you look at the literature, most of the focus has been on overutilization. But Dr. Z et al. From Harvard Medical School have shown that underutilization is even bigger problem than the overutilization. As far as the COVID testing is concerned, we have evolved over time. Initially, as I mentioned before, there was a lack of tests. Once testing became available in different formats, there was definitely a lot of inappropriate utilization of the test, as has been highlighted here by some of the headlines we have seen. However, as more data became available, our understanding of the testing improved. Guidelines were refined. Manufacturers also refined the use of the test, thus leading to better utilization of the test. In our lab, in our inpatient testing, some of the overutilization is seen for metabolic panel, electrolytes, CBC, PT, and INR. When we mention overutilization, it can include number of things. Ordering too many tests initially during the initial visit of the patient, or in inpatient, we see more repeated testing of the same tests. Overutilization also includes ordering too many of the low volume tests. In this regard, I'm sure many of you are aware of the Choosing Wisely campaign. Choosing Wisely campaign, along with the guideline recommendations from national organizations, have continued to continue to reduce the inappropriate testing currently happening. In the next 3 slides, I'm going to focus on 3 of the tests that I think are being underutilized or not available, which, if they are available, can have greater impact in our patient care. Currently, nearly 37.5 million US adults are diabetic, and 96 million people are pre-diabetic. About 25% of diabetic population and 80% of the pre-diabetic population remain undiagnosed. And we spent about more than $237 billion in direct cost alone. As you know, diabetes is preventable and treatable disease. It can be diagnosed early and managed properly. In this regard, A1C test is recommended for both diagnosis and management of diabetes. Please, I want to stress here that for diagnosis, you need a lab-based testing because of more accuracy, better accuracy of the lab-based test. However, performance of point-of-care tests have been improving over a period of time, and access to testing point-of-care testing has been also improved. However, they remain underutilized and they need to improve further. Likewise, for point-of-care glucose testing, in gestational diabetes area, as you know, gestational diabetes are related, can lead to a number of complications, both in newborn as well as for the mother. Therefore, early diagnosis and timely intervention is needed and to reduce or lower the GD-related complications. American Diabetic Association recommends a 2-hour oral glucose tolerance test at 24 to 28 weeks of pregnancy in those who have not been previously diagnosed for overt or gestational diabetes. This test requires overnight fast and consumption of a concentrated glucose test, followed by blood samples collection at 0, 1, and 2 hours. And most of the time, these samples are sent to the main lab for testing. We frequently see that, we get called from the clinicians saying that, some of the pregnant women cannot tolerate this stent if there is any alternatives to do this. I would recommend that you do a quick point-of-care test before initiating the drink or initiating the glucose tolerance test. Sometimes we have seen that, at least in some of the patients, we see that fasting glucose is very high even before the testing is commenced. For those people, we route them only the fasting sample, initial baseline sample to the lab to see whether they have the gestational diabetes, thereby avoiding the glucose oral test altogether. So another test that I would like to highlight here is the point-of-care cardiac troponin test. Cardiac troponin is an important marker for myocardial injury. It's very useful for rapid rule-out and rapid rule-in of acute myocardial injury in ED. Recently, high-sensitive troponin tests are increasingly available. They are preferred over the previous generation of the test because of the much higher analytical sensitivity and precision. In the recent years, as you all know, FDA-approved lab-based tests are widely available. However, there is no point-of-care test, high-sensitive test still available. Therefore, many of the rural communities are continuing to use the previous generation of the assays. If, in case if the access to high-sensitive troponin is available, then it can help to improve the acute coronary syndrome-related outcomes in rural settings. Two of the major disadvantages with point-of-care testing are test performance and cost. Other challenges with point-of-care testing are proper test utilization and staff training. Some of these challenges can be overcome by having a good internal control processes, participating in proficient testing, participating in external quality control programs can help to improve the performance of the assays. Likewise, ACC recommends that it is important to have interdisciplinary teams put in place before, to suggest appropriate test utilization. These are some of the things that we can do to improve the test utilization. Likewise, continuous staff training, education, taking advantage of some of the IT tools like clinical decision support tools available can help overcome some of the challenges that we face with point-of-care testing and improve test utilization. These are some of the references I use for my talk. Thank you.
Thank you. Thank you to all of our great presenters today. Excellent information from their areas of expertise. We will now take questions from the audience. I have one question that will start us off while we continue to gather more additional questions. And please do submit your questions, all you audience members out there. in the Q&A box at the bottom of your screen. Please do that, and we'll try to get to as many as we can. So one question for all of our panelists as we kick this off, how did your health system balance quote unquote platform fatigue, if you will? So, you know, the variety of different platforms out there that you could have evaluated and implemented, and maybe you did for various reasons, or you didn't for various reasons. So how did you balance that platform fatigue versus the need to accommodate increased volumes and faster turnaround times for COVID testing? Did you begin consolidating platforms once the push, you know, once the high volume setting subsided? And did this mean saying no to some health systems requests for either capacity or turnaround time? I guess just give us kind of your overview of what that was like at your institution.
Yeah, I can start with that, Dr. Donato. So we had at one point 11 different COVID methods, SARS-CoV-2 methods in the enterprise, 8 or 9 of those in Rochester. So I think the initial approach, of course, we're a reference lab at Mayo Clinic Labs. And so we had one arm, which was really, we knew we couldn't take on the world's COVID testing, but what was a good target to shoot for, and for the high throughput, how many different platforms? But I think the local needs, again, the rapid testing needs were more difficult to manage to the enterprise. And as you know, because Dr. Donato, you participated, we had a rapid testing group. We met 3 times a week for almost a year. And so we have more capacity with the innovation team to bring in new platforms in Rochester. So what we did is we committed to bringing in more platforms for rapid testing in Rochester. And then most of our other enterprise sites were more comfortable sticking to what they had. And then we would manage total capacity and total reagents across the enterprise. So as we brought in more platforms in Rochester, we could look at, well, how many can the Mayo system get for a Cepheid or Liat existing platform and shuttle those other places. And that's really what we did, I would say, certainly through the Delta surge. As we got to Omicron, we began to realize we cannot just go to the practice and ask how many do you need for rapid tests, but we had to really reverse it. So for Omicron in late 21 into 22, we really reversed it and said, here's what we can do. And we'd already started consolidating rapid testing platforms by then. Here's what we can do. You decide, practice, how you want to use these. You want to keep all the surgeries, testing all the surgeries. You want to test all the ED, all the admits. How do you want to use them? So really flip that between Delta and Omicron from what do you need? We'll find a way to do it to here's what we can do. How are you going to use these tests?
Yeah, our story was very similar at UCLA. So I'll say through 2020, we were taking whatever we could get our hands on, right? Like I sort of undersold it a little bit. We also had 7 or 8 different platforms total. And, you know, I would get an aliquot of 50 tests over here, and I would get an allocation of 75 tests over here. And you would combine everything together to try and equate your volume. Once we got into 2021 and later into 2022, we decided to consolidate because our major manufacturers started to make available quantity of testing that we could use. And so then in that setting, you know, I didn't want to run 7 tests if I could only run 3 equivalent COVID-19 tests. And so we consolidated around those partners that we had worked with for years that finally had their production lines up and running. But wow, I was talking to them every week, right? I was telling them, I don't want to use 9 tests, and I don't want to bring on a test that has no clinical data. I mean, all these pieces, because the EUA was really wild, wild west, right? There were companies that I had never even heard of before offering me what they called high throughput 2,000 tests a day COVID-19 PCR tests. And I'm like, I don't even know who you are. Roche can't provide that to me. Who are you? So it really, but you know, you spend time evaluating because the need was so high. When Omicron came on, though, we were able to consolidate, and that really helped us from a platform perspective.
So our experience was nothing different from what Dr. Garner shared. So we also, because of the supply chain issues, we had to use whatever was available, you know, Cepheid, ID Now, you know, Rapid Fire, Wi-Fi, and lab platforms like M2000, like that. But after, with our experience with different vendors, we consolidated to ID Now and LNTM platforms.
Thank you. That's, yeah, it sounds like a lot of shared experiences there. And likely for many of our audience members as well. Another interesting question for potentially all of you. Did the COVID-19 pandemic and the ability to have, COVID point of care testing and the pandemic itself, did COVID-19 affect the number of requests you get for other forms of inpatient point of care testing, metabolic panel, lactate, creatinine, hematology, et cetera? Was there appetite or clinical need to expand other types of testing to inpatient settings?
Yeah, so I can start on that. And so we came out of the COVID pandemic into the great staffing crisis, and we're still in great staffing crisis. So we've actually seen post-COVID requests for new point of care services, a new location, a new device, go down significantly because there are not nursing staff and respiratory therapists and others to care for patients, their core jobs, much less take on testing. So I think the staffing has really driven down new requests. In terms of total volumes, of course, they plummeted during COVID for ISTAT, blood gas, electrolyte, those sort of things. They've come back to their normal pre-COVID levels, but we've not seen them increase.
I would say for us as a system, our numbers fluctuated up and down, as Dr. Karen points out, but what I've seen is an interesting behavior change in my clinicians. So I get a lot of calls now saying, oh, remember that COVID-19 quick test that you were able to provide that had great sensitivity and specificity? Now give me one for X. And whatever, it doesn't matter what disease X is, right? It can be something cardiac or endocrine, like it could be infectious disease. They all think now that, oh, it was available, and they see these numbers that Dr. Kumar put out where it's like, oh, $45 billion is going to be invested in point of care. Clearly, that means I'm going to get an in-house vitamin D point of care test that's coming back in 5 minutes, right? And so a lot of that, now on one hand, it's great. On one hand, I really like it because it's increased the conversation, and lab medicine is being pushed to the forefront. We can have those conversations. On the other hand, though, it worries me in an integrated healthcare system where I don't talk to my clinicians all the time. So I have my inpatient population pretty well controlled, but nothing's stopping somebody going to one of my urgent cares and trying to sell them something. And then they bring it on from a point of care testing. I don't know what it is. So there is a little bit of that now that is a concern as far as I'm concerned with this particular industry.
Yeah, for us here, even during the COVID, initially there was some reduced in the volume of testing that we did, but our volume has picked up considerably. But fortunately, our clinicians are very understanding. They are patient. They understand the importance of lab-based testing. So most of the increase that we have seen are post lab-based testing, but we are increasing the point of care testing menu. But we have put in place a number of mechanisms to make sure that we really give the thorough thought to before expanding the testing. And our clinicians, we always involve them upfront in any of these discussions. So that has helped to limit the expanding unnecessarily number of point of care tests.
Thank you. Let's see, question specifically for Dr. Karen. Your presentation highlights the importance of laboratory feedback to assay developers to facilitate test improvements. Of course, that was during this very special time of non-FDA, pre-FDA acceptance and waiver status. So can you discuss, moving forward, post EUA testing status, can you discuss what types of modifications, if any, manufacturers can make, which would not alter their CLIA status versus modifications that would cause them to have to go back for regulatory reapproval, such as the FDA in the United States?
Yeah, so there are again, the regulatory approval system's a major limitation. Kind of knew that going in, but I think what's outside generally of FDA regulation are lot-to-lot control and lot-to-lot release criteria. And that was the whole point behind both immunoassays in the lab and point of care, drift over time. And so vendors have pretty much control over how they do that. And we hoped our data would help refine these lot-to-lot QC and lot release criteria, as well as the shipping conditions a lot of times can be modified. And so those both were done in our study that we just did. There were a lot more hardware and software changes, which would have to be a start over with the regulatory approval process and would be major limitations.
Yeah, thank you. That makes sense. Excuse me. For Dr. Gardner, your approach to tailor assay performance to the clinical need or work unit need, high sensitivity versus less sensitive for employee return to work is obviously very pragmatic. Can you talk about the decision-making process there? Was this a team-based approach with physician and work area input? And then also, can you talk about how you maybe balanced FDA recommendations and package insert, terms of use kind of in package insert, and maybe deviation from that indication in the PI?
Yeah, of course. So the first challenge around testing prioritization is, fortunately, we had the foresight to make a committee, because if all the questions on rapid testing had come to me in my laboratory, I would have been quickly overwhelmed because everybody wanted the 20 to 30 minute turnaround time test. So right away in the pandemic, we actually made a testing prioritization committee where members of the C-suite, members of our infectious disease team, members of infection prevention, and then leaders from each critical area. So ED leaders, surgery leaders, anesthesia leaders, which was a big part of it, all got together once a week for 3 years at 11 a.m. to talk about testing, which who's ever talked about that much testing, right? And they would bring the clinical need to that meeting. Then at that meeting, the needs would be prioritized, and lab, so me at that meeting, would be presented with a challenge. We need X, we need, and there was sort of these areas of need. So that I would come back to the meeting the next week and say, here's what I think our solutions should be, here's the data as to why. The rapid testing conversation was heated because antigen testing came on right away, and I held off. I told them, look, we can't bring this antigen testing in because you want to use it for rule out, and it's not sensitive enough to be able to do that. And so every week I was pushing Roche to get that LIAT out and get us kits so that we could bring that on. And then once we did, we were successful in that setting. But I got a lot of pressure for that particular decision. The Abbott ID Now they wanted to bring in, but I was talking about sensitivity there. And so that's a nice segue into the package insert. Honestly, as a lab director, the package insert lies across the board. I don't want to say lies. So the package insert is from a selected set of clinical values that usually makes the test look very good. So in that particular setting, this is why we do verifications as a lab anyway, right? You don't just bring on a test, and I would argue even in the point of care setting, you don't just bring on a test unless you do some level of verification to see how that test performed. And when we brought on the antigen test, we compared it to PCR. I can show you where the CT level cut off and that test stops working. So in that particular setting, even though the package insert said one thing, we knew behavior on the other. And then I will just remind the group, those package inserts never claimed asymptomatic testing was appropriate. Those package inserts were for symptomatic testing 1 to 3 days post-infection. Everybody wanted to use them for something else, but that's not what it said for the clinical criteria they used to validate and get that test through EUA. And so I think we just have to be careful, right? I think we just have to, as lab leaders and as laboratorians, really evaluate these tests and then fit them into the clinical pieces we need to fit them into.
Thank you. Yeah. Question for Dr. Kumar. The topic of appropriate test utilization obviously became very important during the pandemic with the variety of test options out there that we've talked about, different sensitivities, specificities, multiple test options that likely could be ordered at the same time, maybe inappropriately. So could you discuss, are there strategies that are unique to guiding physicians or are or were unique for guiding physicians to appropriate test utilization for COVID testing, or were kind of more the general strategies of test utilization applicable to COVID testing as well?
Yeah, as far as the COVID testing, one of lot of questions that I faced was about what is the right serology test to use in those patients who are vaccinated and those who are infected and later vaccinated. So there was always confusion. Should they use a IgG spike, IgM spike, or IgG nucleic acid? Those are the questions that I faced in the core lab testing. So we were able to guide them to the right test. As far as the other molecular tests are concerned, there was a committee that decided what is the appropriate test to utilize. So, anytime they order COVID testing, it was automatically routed to the right test.
Excellent, thank you. This is more of a technical question, so open to anyone. For urgent care centers, what is the trade-off between PCR and isothermal, and what is best?
So I did, and you know this because you were involved, we did benchtop LODs with one isothermal and a couple of rapid PCRs. That doesn't mean all of them. But as Dr. Garner said, that even rapid RT-PCRs had a huge range. The Liat is sort of absurdly sensitive, maybe too much, whereas ID now actually probably performs in some hands not as well as some of the isothermals. So in general, the isothermals had a higher LOD, and this one we looked at maybe in the range of 5,000 to 7,000 copies per mil. When you get to like the Liat, it was kind of crazy, like what, 12 or 20 copies per mil. So they can be extraordinarily sensitive. I don't know if Dr. Garner has more to add.
No, I agree in this component that it's almost too sensitive, because what we're seeing now is in the post-COVID vaccine era, you might have had COVID 2 months ago and your Liat's still positive, and it doesn't give you any CT values. This is the other part of molecular point of care testing that's rough, is I can't get in the back end and see sort of what level of positivity is there. So it looks like any other positive. And now we've sort of thrown the entire health system off from that patient coming in because they ended up testing positive. So we had to set these parameters of, if you had COVID within the next 90 days, you're not getting tested on the Liat. We're just going to assume you don't have COVID asymptomatically and move forward because of that exquisite sensitivity, which in most cases as a microbiologist, I'm looking for exquisite sensitivity. But in this case, I'm like, could we back off a little bit on the sensitivity of this particular test? So.
Perfect, thank you. Another maybe technical or result-based question. Someone noticed that false positive flu A or flu B results when the patient was actually COVID positive. They mentioned a particular system. I think I'll probably just leave that out here. But did any of you see similar results, similar phenomenon with false positive results?
Yeah, we did, and they were rare, and we tracked it across the enterprise where we had the Liat in use that was the COVID flu A, flu B, and any double, triple positive or flu B positive, because it never really circulated in any of the respiratory virus seasons, was repeated. And they were there. There was an FDA alert about them, but it was quite rare, fortunately.
Mm-hmm. Yeah. So this is a general question as well, and potentially we touched on this already with the team-based approach, but how did you choose the point of care testing platform? What are the important factors to consider? How did you make the decision to put point of care testing product in the lab or close to the patient bedside? What are, kind of a holistic approach to point of care testing and how to make the decision?
I guess I have a quick comment on that for the UCLA Health System, because that was something we talked about a lot. Not which point of care test. We had decided we're moving the Liat, but where to put it. And we decided to put it in our clinical chemistry core laboratory, right? The reason we decided to do that, it was near to our ED. We could still get the rapid turnaround time. At least I have laboratorians performing the test, so it's molecular testing. I'm always worried about contamination and all of the things. And that, because, a high positive, the CT value is like 11 on, that's a lot of COVID-19 in that sample. So once that gets opened, it's kind of everywhere. And our ERs were overwhelmed. Honestly, just the amount of patient throughput, adding that in a true point of care setting was going to be very, very difficult. And so we actually offered near patient testing, but it was in our core lab as opposed to in my centralized microbiology laboratory. Gave us the same turnaround time, but maintained the high quality that laboratorians have in performing these types of tests. So it's almost like we used point of care, not really as point of care for COVID-19.
Yeah, we did similar things. We had most of our volumes were in stat lab, some actually in our virology lab, and our micro kind of made a stat lab within micro because we had so much volume. We did have a single true point of care application. It was an isothermal amplification. It was the one method that allows nose to cartridge, no manipulation. So you swab the nose, you stick it in the cartridge, it locks in, 25-minute answer, and you throw the cartridge away. So the considerations were environmental contamination, staph exposure, need for a safety shield, manipulation vortex in a sample. So the one true point of care we offered, it was fairly low volume, same day procedures, but it was the one that didn't require sample manipulation. It was direct swab to device without manipulation. And so that was the criteria for point of care use at Mayo.
We also, like Dr. Garner mentioned, we also used ID now from the lab rather than putting them in the ED because of the shelf shortages there. So it worked out very well for us.
Yeah, a lot of shared experiences there too. Yeah, and I think the question continues, where do you put the testing to meet patient care needs, but also to not burden the staff in the work unit? That's a big consideration. So I'm sure a lot of similarities there between us as well as a lot of our audience members. So I think we've covered most of the questions submitted. There's some comments I'll leave in there for the individual panelists to read on their own. But weren't actually questions. But I wanted to just leave us just to ask all of our panelists if there's any final remarks that you'd like to share with us that you haven't had a chance to touch on during our session today.
I would just say we learned a lot about rapid evaluation and implementation of tests. And so whether this model we thought of when we got funded for CAP Foundation works, I think all of us have learned that, there's this whole thing, COVID time, and we usually take months to build tests in our IT system and evaluate, implement. So we've learned we can do things a lot faster when we have to.
I'll speak to laboratorians and clinical lab directors who are not involved in point of care right now, but who are on this call, as opposed to sort of people working in point of care. Embrace point of care, right? I think that, especially in the clinical microbiology world, for the last decade, it was a little bit seen as what's clinical microbiology is what's run in the laboratory, and point of care is something that we're not going to touch. I think that is not the direction that the field is going. That doesn't create equity as far as access to healthcare. A lot of the slides Dr. Kumar pointed out are a lot of what I work on in my research setting. If we're truly going to reach the patient populations that are out there, we need to embrace point of care, and point of care needs the laboratory eye to be able to evaluate, communicate to clinicians when the test is good, when the test is not good, and really put the pieces in place for high quality testing. And that's what we do as laboratory professionals. And so I would just sort of ask, if you're resistant to point of care, it's coming for everything. Chemistry, it's coming for all areas. This COVID-19 pointed it out for infectious disease. Embrace it, because, there are some new wonderful technologies that are out there. It's not the old days where the point of care test is going to be so bad that you wouldn't even consider it. There are point of care tests that are coming that are going to be equivalent in their sensitivity and specificity. Maybe not high throughput, maybe a lot of other things are going to be different, but they're at least going to be good tests. And so we need to take that on as a laboratory group and really embrace that so that we can move forward for patient access.
Yeah, I also agree with that. So point of care testing improves the accessibility to testing and improve patient care. So we need to take that point home.